I am Allison Cuellar, the newly appointed Director of CHPRE. Welcome. I did want to point out that we have several upcoming webinars, one on pharmaceutical policy, one on health insurance coverage, and one on public health, and I hope you will join us for those as well. It is my pleasure to introduce Len Nichols, my predecessor in CHPRE, who is Emeritus Professor of Health Policy at George Mason and a non-resident fellow at Urban Institute. Len, please walk us through policymaking in a post-COVID election year.
Well, thank you. Thank you, Allison. It's a pleasure to be here, and it's a thrill to be doing my first Emeritus event. So that's exciting for me, if not for y'all. But anyway, we've got a great panel today, and I must say, you know, when this panel was a gleam in my eye about 6 months ago, I just assumed we'd be talking about things like, you know, repeal and replace and Medicare for all and public option, maybe some drug pricing policy for fun and how to pay docs, that proverbially interesting stuff. And obviously the events of the last 3.5 months have changed pretty much everything, but the panel we have is phenomenally versatile, and of course they've been deeply enmeshed in all of these activities related to COVID itself first, and then the stimulus packages or bailout packages or the support packages, whatever you want to call it, that Congress amazingly got done pretty quickly. But there's still a heck of a lot of fallout out there and a lot of stress and strain, and of course the recent protests over racial injustice have brought it all home in a more poignant way. So we couldn't have a better panel to talk about the policy environment in Washington as well as in states and in what I think is perhaps the single most ultimately important sector of our healthcare world, and that is primary care and family physicians. So we'll start with Audrey Smith, who's the legislative assistant for Senator Joe Manchin from West Virginia. Audrey also is an expert in rural healthcare, which is a perfect match for West Virginia, and was a former student of mine at George Mason, so don't blame her for her health econ background, but it's actually pretty good. She taught me a lot that semester. Then Stuart Portman, who is on the majority side at the Finance Committee, of course, the single most important committee in the Congress, and Stuart is one of those people who not only understands Medicaid, but also drug pricing policy, and no doubt by now, COVID and epidemiology. And Stuart is one of those rare people like Audrey, who talks to people on both sides of the aisle and maintains respect on both sides of the aisle, which is why they are our congressional panel. They'll be followed by Shawn Martin, who is probably the best spokesperson there is for primary care and family practice. He has been executive vice president and a strategic leader there for a while. He's about to become the CEO in August. Congratulations, Shawn, and condolences. I know those words are appropriate there. But Shawn has personally taught me a lot about physician pricing policy. He's my go-to guy when I don't understand the regs that come out, and he's extremely good at teaching as well as advocating on behalf of the primary care sector. And finally, Hemi Tewarson, who's the division director for the Center for Best Practices at the National Governors Association, has been a leader for some time in both helping states figure out what to do and also tracking what's going on in the best practice sense to show other states what they might consider. And I noticed in reading the bios that Hemi is both a lawyer and an MPH, but the most important degree, I think, is a bachelor in psychology, because that no doubt enables her to deal with all those politicians she has to deal with on a daily basis and how to make them all feel like it was their idea. So we're quite thrilled to have this panel. We're going to go roughly in that order, and we'll have sort of 6 to 7 minutes of remarks. A couple folks have slides, a couple folks don't, and then we'll have some Q&A from me and maybe from each other, and then we'll turn to the audience. So if you have a question, just type it in the, is it chat, Terang, or Q&A? What's it called? My world says chat. You can submit questions written, and we will curate them and combine them and address them to the people as appropriate. So let's start with Audrey. What the heck's going on Capitol Hill and in West Virginia these days?
Well, as you alluded to, when we started this year, was not expecting to have to respond to a pandemic. We were looking at health extenders in May. West Virginia leads the country in substance use, drug overdose deaths. So substance use disorder and response and opioid response was one of the big things that we were looking forward to this year, and potentially ACA repeal replace conversations. And we're quite taken aback when the pandemic hit. And it's obviously, I think a lot of people here have been able to watch as Congress passed now 3 different packages to respond to COVID, the CARES, the $2.2 trillion being one of the big ones. But one of the things I wanted to talk about today is a little bit of what you don't necessarily see on the headlines as a legislative assistant and staffer for a personal office. What we do a lot of is responding to constituents. So I thought I'd cover a lot of what we've been doing to contribute to the stimulus packages and looking forward. In the early part of the pandemic, when we all went home from our offices on Capitol Hill to our at-home offices, I was fielding a lot of calls from concerned doctors and patients and providers who didn't really know how to function in this day and age, and what our personal offices call casework. So doctors who were trying to treat patients but unable to furnish telemedicine, specifically our rural health centers. And if you're unfamiliar with West Virginia is a state of 1.8 million people. We have had 46 hospitals and are pretty much a rural state, very mountainous. Appalachia is what we like to call it. And travel between 2 healthcare providers is very difficult. And making matters worse, there's not a lot of cell phone coverage and very little broadband. So telemedicine, being able to help our rural health providers to be able to furnish telemedicine was one thing. And on a second level, we had to deal with a number of our Medicare patients only having access to landlines to receive a check-in from their doctor. And so we worked in conjunction with the administration for improving payment parity on audio-only telehealth. And then West Virginia started to experience another issue that grew off of this pandemic. West Virginia is primarily Medicare, Medicaid payers. And when our hospitals and health providers stopped doing non-emergent procedures, we saw revenue in our hospitals and providers drop. We had a hospital that is about 9% commercial payers, which is incredibly low, and had a census of about 6 patients with 92 beds. West Virginia now has seen 3 hospitals close since the beginning of this public health emergency, meaning that for my boss and from our view, providing support to our rural health providers has been a major initiative. My boss has been pushing for a rural health set-aside within what's called the Provider Relief Fund, which is now a $175 billion account that just provides support to our health providers who have been struggling because they've had to up the purchase of infection control, PPE, testing supplies, pop-up tents outside of their facilities to be able to furnish tests for people with COVID, being able to still cover healthcare and benefits for their employees and salaries while not being able to develop the revenue since they're not bringing in patients. So we've been working hard to get that money to these providers that need it. And we're still seeing just the revenue and the budgets of these providers are just bleeding and struggling very hard. Another issue that West Virginia is fairly unique in is that I got to delve into pretty deeply is what is the definition of rural? Most people picture rural, they think of Wyoming. I think Wyoming has a state of about 50,000 people. It's pretty frontier, rural, and West Virginia at 1.8 million is a fairly small state, but it's also geographically small. And being close to DC gets considered rural a lot, urban. And if you've ever been to West Virginia, you've had the privilege of driving up the mountains. We have a lot of one lane, we like to call them haulers, highways going up a mountain, and it makes the travel time between your house and hospital incredibly long. And if you're familiar with healthcare, as I'm assuming everyone here is today, there's something called the golden hour, where if you have a heart attack or a stroke, you need to seek care. And while 46 hospitals sounds like a lot, when your travel time between it is over an hour, you put lives in danger. And in a state where we lead the country, as I mentioned earlier, in overdose deaths, that travel time is incredibly important. And the USDA utilizes a economic measure of travel time for employment to define what rural is. And it's based off of measurements from 2007 to 2009. And what was happening during that time was the Great Recession. A lot of coal jobs were going away. So travel time for employment was very long. And we ended up with several of our counties in West Virginia suddenly being urban, which meant that all these rural funds that we had been fighting so hard to get to our hospitals who were on the brink of shutting down or shutting down suddenly weren't getting there because they were somehow classified as urban. So we worked with HHS on how to define rural, how do you get the money to these hospitals and these providers. So that's kind of more of the granular what we're doing. And looking forward, we're still in a pandemic. West Virginia has been very lucky with fairly low numbers. We're testing about 5% of our population now and only have about a 2% positive rate. So West Virginia has done fairly well, relatively speaking, and is on its way to reopening. We now are dealing with having to ensure that our providers that are now doing non-emergent procedures, like our dentists and optometrists, are able to get the PPE they need to be able to treat patients safely. And now we are having a conversation on health disparities among our minority community. West Virginia is about 97% white. We have about a 3% African-American population. However, that population represents 7.6% of our COVID cases. So there's obviously some pretty significant health disparities there. And as I mentioned with our rural population, healthcare access is a big issue in West Virginia, and ensuring that we have access and we're supporting our doctors to be able to furnish this care. And to add on to that, we already led the country in overdose deaths. We are seeing a huge uptick in relapse and crisis care needs within West Virginia and across the country. This extended period of isolation really impacts mental health. And when our behavioral health providers are struggling to keep their doors open, respond to cases, furnish telehealth to patients, there's a big conversation on how do you continue to offer treatment for substance use disorder to patients when they're hard to reach. They're geographically hard, it's difficult to get them into treatment. Now add a pandemic on top of it, makes it even more difficult. And we're looking at how to move forward on that response. And to add on to that, we also have general duties as senators. My boss sits on the Senate Appropriations Committee, and he's specifically on the Labor, Health, and Human Services Subcommittee. So we need to appropriate money to those accounts. So we're juggling pandemic response, still dealing with substance use disorder, ensuring people have healthcare coverage through Medicaid and ACA exchanges, since most people are losing employer coverage at this point, and ensuring that we have providers to furnish care, and then just do basic appropriations, which is never so easy. So there's a lot happening as a health policy staffer, and a lot of conversations happening with doctors on a daily basis in hospitals, and a lot of issues I never thought I'd have to deal with, getting to go through cost reports and figuring out how hospitals bill and doctors bill. And I now can talk about CPT codes like the best of them, because you need to figure out what payment each code, what codes everybody needs to send, and then work as the liaison between the agency and your providers when things are so fluid and changing so rapidly. So that's kind of what we've been doing in a nutshell, and a little bit of a West Virginia specific, but happy to talk more or answer any questions.
Thank you, Audrey. That's fantastic, and sounds like you haven't slept much in the last 4 or 5 months, that's for sure. And I'm pretty sure Stuart doesn't sleep much either. So, Stuart, what's it like in the committee?
Yeah, and I think sleep is an interesting commodity that we get to talk about a little less than we used to, but it's good to be with all of you. Happy to chat. Len always puts together a great panel of people, so it's good to see all of my fellow panelists who I've gotten to know throughout the years as well. My role on the Senate Finance Committee is to oversee all policies that relate to Medicaid, the Children's Health Insurance Program, the ACA exchanges, and any sort of health tax. So in today's world, that involves HSAs, it involves the advanced premium tax credits in the ACA, it involves conversations around credits related to COBRA. All of that is, it means that the day-to-day gets to be very exciting, whether or not we're talking about coverage or we're talking about response to the specific pandemic, or we're talking about other issues that existed prior to the conversations on COVID and that will exist after the conversations on COVID. Because at some point, even though it feels very distant, we will have conversations on legislative packages that are not related to COVID response. And so just to give you a flavor of what we're talking about here, we're spending a lot of time really focusing on a few specific issues, and then obviously the COVID response. So the Senate Finance Committee, and Len's always so nice about giving the expansiveness of it, but since it does oversee taxes, trade, healthcare, and Social Security, and it adds up to about 53% of the federal budget within the jurisdiction, we take a very holistic view of the issues that we're facing. Chairman Grassley has spent a lot of time and energy over the last 16 months, really, 17 months now, talking about prescription drug pricing. He has made that a tenet of what he would like to get done while he is chairman, and has continued to emphasize the need to reform prescription drugs. We have talked to him. That feeling has not changed in light of recent events. The understanding that there are going to be innovators and we should reward innovation, I think, is one of the things that generated a lot of his original feelings, that in America's healthcare system, we talk a lot about symptoms and not a lot about the underlying issues. And while you all know that through your various lenses, we know that also plays a role in our policy decisions as well. There's a lot of ways to talk about the surface level issues of prescription drugs, but it takes a lot of hard work to actually dig into what are the roots of price increases and how do we change that. So there's been a lot of discussions on the payer side on whether or not it's Medicare changes or Medicaid changes to discuss what that could be. We've also spent a great deal of time internally talking about maternal health. And perhaps less well known is the conversation that we've had bipartisan to try to dig into some of the reasons why the maternal health outcomes are not great in the United States, and why health outcomes during birth and immediately after birth need a lot of work. We know that the governors have spent a lot of time on this, and we actually took a cue from them. I will let Hemi speak a little bit more to that as well if she so chooses, but we saw a lot of action taking place in the states and realized at a certain point some of the issues that exist do require Congress to fix them, whether or not it's a conversation on coverage or payment, or it's a conversation on data. Oftentimes in healthcare, while there's a lot of data, it doesn't connect, it doesn't talk, it doesn't make the job easier. It creates more complications, and that doesn't need to be the case. So we think we can try to solve some of those issues with this broader effort. But those are two examples to say that big picture, the majority of Congress's time is still spent talking about COVID response. In my role focused on Medicaid, there's a lot of state-specific work that we are doing. We are talking to the provider community, we are talking to Medicaid directors, we're hearing from governor's offices about what is working and what is not, how there are budget shortfalls. And then politically, the reason that our jobs are so exciting, I'll say for Audrey and I, is because we get to both, we have to make some balancing decisions. We hear a lot from states that they're having some major budget shortfall issues. And they need to find a way, and Congress is going to need to find a way to help them to make up those budget shortfalls. Then we hear from members of Congress who say they'd love to help the states, but also they want to help the provider community. And if both the provider community and the states are asking for the same mechanism to help them, we have ourselves a little bit of a policy impasse, and we have to figure out how to get past it. I'm not going to, pontificate about what we're going to do at this exact moment in time, but I will tell you that that's the sort of decision that we have to make. It's we hear from our governors on one thing, we hear from the provider community on another. Someone has to make the decision. It's the members, and we get to advise them on how that should go. And right now, there's a lot of those moments. We're talking about behavioral health. We're talking about home and community-based services. We're talking about the role of pediatricians. There's a lot of hospital-specific work happening right now that Audrey spoke to beautifully about the issues with elective procedures and changing of beds. You're talking about nursing homes, which are both major hotspots, and also you have actual care that needs to happen. How do you create a system where you encourage a larger workforce at a time that you're trying to keep people further apart? There are bigger picture questions that we are trying to address through all of these legislative efforts, and I think we will continue to. The timelines are always shifting, but there's more that we will do as time goes on. So I just say that as an entry to, our focus in Congress is to focus on some issues that are going to last beyond this and some issues that are going to be highlighted right now. And how do we balance that in a legislative vehicle and advise both the senator that I work for, Chairman Grassley, but then also members of the Senate Finance Committee, and also more broadly, members writ large. Part of our job on the committee, and I would be remiss if I didn't say this on this, given the group we're speaking with, is to help advise leadership. The chairman of the Finance Committee is, a senior member, but sometimes there's a lot of issues that require Leader McConnell and Leader Schumer to come together and talk. And while they talk a lot about healthcare, probably more than both of them would like to, given the whole scheme of issues in the world, they often have very specific and nuanced questions, and they turn to the committee experts to ask them for help. And so we spend a lot of time answering questions in that regard too. So it means that there's constantly something to do. It means we are happy even though we aren't sleeping, and we are always trying to find a way to help out as we hear what's going on. So I'll leave it there, and of course, when we get to the questions, happy to answer.
Thank you, Stuart. Fantastic job, and I appreciate what you're doing up there every day. And I did not know about the maternal health focus, so we'll definitely come back to that in the Q&A if nothing else. So, Shawn, you've heard both Audrey and Stuart tee up the need for more support of primary care. How are we doing out there?
Well, Lynn, first of all, thanks for having me. Congratulations on the Emeritus status. It's a reflection of a good career. For those that don't know, Lynn and I come from the I-40 corridor, as I like to call it. He got the part with the trees, I got the part with the wheat fields. But we each took the migration across I-40 to the East Coast at some point in our careers. So I do have some slides. If we can pull them up, I can talk a little bit about the state of primary care. If not, I can just verbalize those.
I think Tarang is going to pull them up here. Just give us a second.
Slides are already there. Can you see that?
All I see is the first. I see the panelist slide, Tarang.
Can you see the slides now?
I don't, but oh, there they are. Okay. Yes, now I can. So the next slide after this one. So I'm going to talk a little bit about the future of primary care and kind of the state of where we are. And I think there's been some unique aspects that have been talked about of the COVID pandemic. The healthcare system was, facing tremendous downward economic pressures, whether it was urban or rural or primary care hospitals, both Audrey and Stuart spoke to this, the pressures on hospitals, the pressures on overall costs, the pressures on purchasers, employers. The healthcare system really was under great stress prior to the pandemic, and the pandemic certainly added a layer of stress to the healthcare system that was unpredictable, but also that we were not very well prepared for, and thus necessitated quick and what I think has been really appropriate congressional action to infuse cash and infuse new policies into the healthcare system to extend access. So next slide. I can just verbalize them. So a little bit about the state of primary care. So after about 3 weeks of the pandemic, we started putting surveys in the field on a weekly basis in collaboration with others around the country. And what we quickly found was that about 80% of primary care practices had experienced a greater than 50% reduction in volume. That number is still about 70%. So about 70% of primary care practices are operating at about a 50% pre-pandemic volume today. About 80% of primary care practices report being economically stressed, which we list as somewhere between a 4 and 8 week window of operation. So it's not just small independent practices that are feeling economic stress today. It is practices of all sizes and all locations that are under operational stress due to decreases in volume and also rapid changes in the policy arena. About 35% of primary care physicians in the country do not believe that independent primary care practices will survive the pandemic. They think most physicians will become employed by larger healthcare systems, and there will be greater consolidation in the healthcare marketplace. And if you live in non-urban settings, that statistic is really alarming. Independent physician practices are the real fabric of the healthcare systems, particularly in suburban, exurban, and rural communities. And when you think about those practices potentially not being in existence moving forward, that's an alarming trend that we're very concerned about. And then about 40% of practices have indicated that they have furloughed or laid off staff. That's a pretty consistent number. Everybody can probably point to this for all sectors of the healthcare system. 40% kind of seems to be about where people are, whether they be hospitals, et cetera. So I wanted to talk a little bit about just kind of where we are in primary care and from a policy perspective and primary care spending versus other spending in the healthcare. And the numbers I'm going to use are from 2017. So they're a couple years old, but they're pretty consistent from a percentage basis. So when you think about investment in primary care, so primary care is about $87 billion in annual medical spend, and you compare that to specialist physicians is about $266 billion, pharmaceutical is about $381 billion, and hospitals are about $415 billion. When you inverse that pyramid and you think about the percentage of care that those various entities and providers have, it's almost the complete opposite. So we spend about 5% of our overall spend on primary care, but they account for roughly about 60% of the overall patient visits in the course of a year. We spend about just under 40% of our total spend on hospitals, but they account for about 7% of the overall patient visits per year. So we always claim, from the primary care perspective, that our healthcare financing system is upside down. We spend a lot of money to provide services to very few patients. And there's a lot of reasons we do this. Hospitals have regulatory requirements that with respect to staffing, safety, their equipment is more expensive. I'm not disputing the spend on hospitals. It's just the comparative factor of how we spend on primary care. So over the course of 2002 to 2017, primary care spending actually went down as a percentage of the overall healthcare spend. It went from about 6.5% of overall spend in 2002 down to about 5.4% in 2017. Simultaneously, we had a rapid increase in the prevalence of comorbid chronic conditions in the United States. We had an aging population, So at a time that we had increased need for primary care, we actually had decreasing investment in the United States. And there's lots of reasons, policy reasons, economic reasons, consumer reasons why this has happened. But I just want to flag from a policy perspective, the need for primary care increased over a 15-year time period, and our overall investment from a financial perspective actually decreased simultaneously. Primary care is documented through literature around the world, certainly in the United States, that the higher prevalence of primary care, the better outcomes and lower per capita cost. We've seen this in study after study, ranging from the Sentinel Dartmouth study back in the early 2000s, all the way up to today. Most recently, JAMA published an article about the relationship between primary care and overall healthcare spend. When you have continuous primary care, healthcare spending is equated to drop on a per capita basis of about 20%. So you spend about 20% less if you have an ongoing relationship with a primary care physician. So the future of primary care is a little bit at a crossroads. It's underinvested. It has great utilization pressures on it. I would kind of summarize in 3 ways. I think our attitude towards longitudinal primary care needs to be recalibrated in the United States. We tend to think of healthcare as episodes of care. So we provide an episode of care, and we really have lost concepts of longitudinal primary care. So relationships between individuals in primary care over the course of their lifetime. We also have come to the realization, and COVID certainly put a bright spotlight on this, that the fee-for-service system really is incapable of supporting the primary care system that patients really need. Fee-for-service is dependent upon units of care, units of time, and sites of service, and that's really the opposite of what a good longitudinal primary care really is. Primary care is a continuous relationship around a patient and a care team. Fee-for-service is driving units of care, and those 2 things are at conflict with each other right now, and COVID put a spotlight on it. The third thing that I would tell you is that primary care practices that were on a prospective payment model, so some type of value or prospective payment model, adapted much more quickly to the pandemic. They implemented telemedicine at a much more rapid pace. They had less economic pressures in the early days. That's since balanced out across practice types, but they were able to adjust much more quickly. And everybody adjusted quickly when it came to telemedicine. We talked about this, even though there were hiccups in technology, the addition of the phone-only or audio-only visits was important. But our survey data said that about somewhere between 20 and 25% of family physicians were using telemedicine or virtual health on a continuous basis. Prior to the pandemic, 4 weeks into the pandemic, that number was over 80%. So the rapid adoption of virtual health and telehealth platforms was pretty remarkable to see inside of family medicine. So Lynn, I would stop there. That's kind of the state of primary care as of June 1st.
Very good, Shawn. Outstanding job as usual. So let's turn to Hemi, who I know in a way has been dealing with all of these swirling things, how to deal with immediate COVID, how to think about maternal health over time. I love the fact that y'all have been leading Stuart down the primrose path there. That's a good marriage to encourage. So Hemi, tell us about the states. And I think you have some slides. Terrain, can you load them?
Be here. Thank you for having me. Can you all hear me? Yes? Okay, great. While we wait for the slides, I can just do a quick intro. For those of you not familiar with the National Governors Association, we represent all governors, so red and blue alike. We are the oldest organization serving governors over 100 years. And within NGA, there are 2 parts. There is the Center for Best Practices, where I lead the health division, which is really a think tank, support network, do all things state needs, governor's office need on policy. So really helping them think about what are the best ideas out there, how can they move things forward, where can they turn for help is what we do. We also have Office of Government Relations, which is really the lobbying arm of NGA, but we work very closely together, and all of our work directly with governor's offices feeds into our request for Congress and the administration. So that's how we're organized. I will have to say, you know, I had my 6 mission areas that we were going to really invest in 2020, where we were talking about drug pricing, and we were talking about maternal child health, and we were talking about opioid and substance use disorder, and how to really move all of these programs along, and data and older adults in terms of real policy change at the state level. Because I'm biased, I feel like a lot is happening at the state level now, and we really have to double down and really help them move things forward. And then, of course, we were hit by COVID-19. And I have to say, for our folks, our governors and their staff, it has been 24/7 working on this topic. And, you know, we have all learned collectively I know more about PPE now than I ever knew before. And, you know, ICU capacity and contact tracing and surveillance, public health, you know, departments knew about this already. Well, now the rest of us are learning about it. So I just wanted to talk about a couple of things. You know, in terms of what are governor's priorities in the context of this epidemic, you know, short and longer term is their budget. They are, you know, really facing right now some significant budget shortfalls. They've had different presentations where, depending on which state you're in, they can rate the projections and their estimates, things can change, you know, range from 10% to 70% cut in your state revenue. A 70% cut in your state revenue is a really hard thing to address. States have to, unlike the federal government, have to balance their budgets. So they have to find the money, which means all you can do is cut. So I think there's a real concern around how to address that and how do we do that in a way that we don't really eliminate all these public programs that we need right now in the context of COVID-19. I think the other thing that we have been working a lot on, you know, in addition to many of the other pieces, is the reopening. So, you know, states, you know, different types of requirements and plans and all of that had effectively slowed everything down to make sure that there was not disease transmission and to slow down the rate of transmission. And of course, there was incredible pressure to open back up because of the loss of employment, impact on individuals, families, and others. So you're seeing now states across the country starting to loosen their restrictions to figure out how to get back to where we were. And I think this is going to be a long process. You know, if you talk to a lot of epidemiologists, they talk about, okay, there could be this second wave in the fall when we have people with flu and people haven't gotten their vaccines, they haven't been getting their primary care. And, you know, as the flu starts coming into play, there's going to be an impact on whether it's COVID or not. But you're also going to see before that second wave outbreaks happening between now and September as things start opening up. And if you've been following the news on this, there's already some states that have seen some uptick, states like Arizona and Florida, where there have been higher number of cases. In Arizona, the hospital system's now reporting their ICU capacity is getting reached, and they're really worried about, you know, they have to activate their emergency plans. So in New Mexico, just yesterday, the governor's office notified us that they are going back a phase because of the number of cases and the level of hospitalization. So this is going to be, I think, a little bit of a yo-yo, and different states are going to approach it differently. And if you have an interest in that, maybe we can send the slides around afterwards. I had in my slides on our website, NJ website, we actually have a tracker where we are real-time tracking what different states are doing in terms of statewide closures, requirements around mask wearing, state limits on gatherings, you know, quarantine orders for interstate travel and statewide school closures and the like. So if you have any interest in that, I would recommend that you go look at our website because we really are trying to keep up to date with all the different things that are happening across the state. We also have a host of resources on that website with respect to the memos that we've been put out to governor's offices, as well as the different reopening plans that states have put out and different levels of federal guidance. So on a variety of topics, so I encourage you to kind of look into that if you're interested. A couple of things where we are really spending a lot of time on, which, boy, I didn't know anything about these topics before March, and now I do. A lot of time on testing, really understanding different types of testing, where states need additional testing resources. And our biggest issue right now is how do we pay for testing? So for example, some of the big drive-through sites had been contracted directly with HHS, like CVS, for example, and their big drive-through sites are paid for with federal dollars. Well, those arrangements are ending, and so there's now a bigger push to have everything billed to insurers. And I think there's questions around what are the insurers going to pay for, especially when you have folks who are asymptomatic getting tests. There's also a question about how to reimburse the serology test, which is a test for the antibody, which I personally think is going to be a very useful test once the reliability is all ironed out for different populations, because then you'll know who's had it, who's had COVID and who hasn't. But there's questions around reimbursement for that as well. So I can say that has not been figured out. We've been having multiple calls on this topic with state officials, plans, companies, everybody. And people are still whirling around in terms of what should we do about this reimbursement question, not to mention those who are uninsured. I think the other area we're spending a lot of time in is contact tracing and surveillance. So if you're interested, we're actually going to have a paper out on contact tracing workforce, which we'll put on our website. And we are really trying to help states figure out how to scale up the workforce to do this work, and also how to get the public to trust. I mean, I think that's a key element to all of this, public really responding to, you know, if you've been exposed, you've got to let your public health officials know and respond to contact tracers. So when we start opening up, states, regions, and counties and cities are going to be able to really figure out where the outbreaks are. That's going to be key to all of this, and to keep, you know, moving forward on an economic growth pattern. Vaccines and treatment is something we've been following a lot on, where, you know, there's a longer timeline for that. Treatment is in the shorter term, vaccine in the longer term, and what will that mean to really end this epidemic? And then I wanted to just talk a minute about Medicaid. So, you know, the Kaiser Family Foundation, states are starting to see an uptick in Medicaid enrollment, but the Kaiser Family Foundation has projected that, you know, there could be potentially as many as 17 million people newly eligible for Medicaid by January of 2021. It's a lot of people. And 6 million eligible for tax credits through the exchange. Now, whether those numbers actually hold, we'll have to see, because we've seen some weird things with employment numbers, and so we'll see where that goes. But even if it gets close to that, that's a lot of people on those programs. And I think states, with the budgets that they have right now, are really concerned about how they're going to be able to cover those populations. We here at NGA have made, the governors have made a request for $500 billion for state fiscal relief, and an increase of 12% in the enhanced FMAP, federal matching assistance percentage for Medicaid. And in my history of NGA, I've been there 6 years, we've never made a request like that. And I think that is in recognition of the real fear. And, you know, this is conservative governors coming on and really pushing this as well. This is not just the Democratic governors who are, you know, maybe have been more historically asking for federal dollars. So I think there's real concern about what do we do with these budgets? What do we do to keep our economies going? There are questions around, you know, for some economies that are really dependent on tourism, for example, where, you know, what's going to happen with those pieces of their economy if they don't come back. And, you know, some folks like Moody say this could be, you know, 18 months to 3 years to 5 years for some states to get back to where they were. So whether that all pans out, those are the types of conversations that are going on at the governor's level, and lots of concern. So, and finally, because I want to make sure we have time for questions, I did want to mention the provider issue. And Shawn, you were very articulate in talking about what your members are experiencing. We have been hearing the same, a real concern for different types of providers in the state. And what I really worry about is some of these networks were already somewhat fragile before we began, the behavioral health system, some of the primary care practices, especially out in those rural areas, the rural hospitals. I mean, in some states were already struggling, right? Some of them were already going to close. So, you know, what is the long-term impact, short-term and long-term impact of COVID, and what is our healthcare system going to look like on the other side of this? Certainly more move to telehealth. I think telehealth has you know, we've been working on telehealth for years, and my God, we've done more on telehealth in the past 3 months than we did for 5 years in terms of getting people to try it. But that's not going to solve everything. And, you know, you're still going to need folks to get certain types of preventive care. You're still going to need to have some plans for those rural areas. And so, you know, we've been thinking about, and we've been trying to talk to state leaders about, you know, how do you switch to different payment systems, and some of what Shawn's been talking about. And those states that hadn't started on that path already really are having trouble being able to do that now, just in terms of bandwidth and everything else going on with COVID-19. So I think it's going to be a slower process. And I'm just really concerned about kind of the loss of services in the interim and whether we're going to have a robust enough system when we come out of this to make sure we're getting the type of care that is necessary to really ensure a healthier population. So maybe I'll stop there so we can be sure to have time